morning, everybody.
Good morning, sir.
Very happy to be here as part of the SMART program. First time. A big thank you to Mukambika Madam, sir, and all other coordinators of this program for getting me on board. I have been given an enormous task of doing two most important aspects of clinical medicine, that is arterial pulse and venous pulse, in 1 hour. So I have made slides and I'm trying to be as simple as possible. But
Hello. Without much ado, we will proceed to the slides. We will see the arterial pulses, arterial pulse in these sections. We will see the definition and then see how you describe a normal pulse, then scale for comparing the pulses, and then examination of the pulse under all the heading which you are familiar with. You are all into medicine now, clinical medicine, from third year, second year onwards. So rate rhythm, volume character, radiofemoral delay, vessel wall thickness, peripheral pulses, and blue ear pulse, apex deficit. So this is a definition. It's an expansive pressure wave originating in the aorta. It originates in the aorta due to ejection of blood from the left ventricle into an already filled aorta. Aorta is already full with blood. LV is ejecting into an already filled aorta. So there is an expansive wave which will propagate towards the periphery at a speed of 5 meters per second. Remember, it is not the speed of the blood column. It's a wave along the arterial wall that is going at a speed of 5 meters per second, and blood column moves only at 0.5 meters per second. So this is the arterial system starting from the aorta. Of course, when the pulse wave reaches the carotid artery much earlier than the brachial, radial and femoral artery, that we will see later. So this is how you describe the normal pulse in a graph. I have put a mnemonic there, patched. There are 4 waves in a pulse wave. Pulse wave is a positive waveform. It's a positive waveform recorded with a pressure manometer inside the artery. So you see this graph measured by a manometer, which we do regularly in the cath lab. It has got a percussion wave, then an anacrotic shoulder A, then T for tidal wave and D for the dicrotic nodes. Okay. See, let us see how these waves are formed. Percussion is due to nothing. It's the impulse generated by the contraction of the LV. The blood is going into the aorta. That's the percussion. Then tidal is nothing but some echo happens. Go to the upper limb, upper part of the body, echoes. That reflection will collide with the percussion wave to form the tidal wave. And then you have the dicrotic wave. When the descending limb, the pulse, in the diastole, suddenly aortic valve closes. A sudden little positive deflection. That is called the dicrotic. You understand? So that is again kind of a plus between the little pressure increase due to the aortic valve closure and the reflected wave from the lower part of the body, distal part of the body. So this is how the waves form. See, when you examine the pulse, you know how to examine, but many a time I have seen students not properly looking at the carotid pulse and the distal pulses. You know brachial pulse, you know radial pulse. When I ask to examine the popliteal, the tibial pulse, posterior tibial and dorsalis pedis, many a time I find they don't do it properly. See how you check the carotid pulse. This is the prominence of the thyroid cartilage there, lateral to thyroid cartilage, medial to the sternocleidomastoid, with your 3 fingers or with the thumb, preferably the 3 fingers, index, middle and the ring finger. Don't give too much of pressure because you are palpating the common carotid artery. It has got a bulb there at the bifurcation of internal carotid and external carotid. This bulb contains baroreceptors. So if you press too much, especially old people, you may precipitate something known as a carotid sinus syncope. Patient may lose consciousness because of the vasoreceptor stimulation. And second thing, patients may be harboring a plaque. You press too much, the stroke can result. So be gentle when you palpate. Never simultaneously palpate. It may again produce a syncope. And then your dorsalis pedis is nothing but a continuation of the anterior tibial artery going this way and coming like this. So you palpate kind of a little proximal to the midpoint, a little medial to the midpoint. So little proximal, this center point, little proximal, little medial. And the posterior tibial is symbol behind the medial malleolus formed by the tibia. There is a concept called central and peripheral pulses. Okay. If you ask me what are the central pulses, maybe you can name carotid, femoral, and of course the apical impulse, and all other peripheral pulses, brachial pulse and the carotid pulse. These are the two pulses used for assessing all the characters of the pulse. All the characters, except maybe pulsus alternans and water hammer pulse, where you check the radial pulse. Even the dichromatic pulse. All other characters are examined either in the carotid or in the brachial. And in children, when you may not be able to feel, children in infants, less than 1 year, you may use the brachial artery, otherwise you use other pulses. Okay. Pulse rate, you count for 30 seconds, multiply by 2. If you have an irregular rhythm, do for 60 seconds. Be patient. And what is pulse deficit? You count the pulse, say 70 per minute. You count the heart rate, say 100 per minute. There's a difference. 100 minus 70 is 30. Up to 10 is okay. Up to 10 LV contraction may not produce a pulse. But if you have more than 10 contractions not producing a pulse, it is called a pulse deficit. Apex pulse deficit. And it is for you in atrial fibrillation. Okay. And second, marked pulsus alternans. Pulsus alternans is nothing but alternate strong, weak pulses. So if you have 100 beats, 50 will be palpated as pulse. So there is a pulse deficit of 50. So these are two conditions where you have this thing. And right, normal heart rate in adults is 60 to 100, less than 60 bradycardia, more than 100 tachycardia. But in newborns, neonates, less than 1 month, it is up to 140. And in infants up to 1 year it is 120, and in children it is 120. Rhythm. We know our rhythms are regular. Heart produces a regular rhythm because of the sinus node beating, producing impulses. But there can be irregularities, and then you have regularly irregular, irregularly irregular. You have regular rhythm, the last one is normal, then you have ventricular tachycardia is one dangerous thing which can produce a regular rhythm at a rate of 140, 160, 150 per minute. And of course, another dangerous rhythm, complete heart block, at a rate of 40, 30, 50 per minute, again it is regular. So normal, a dangerous rhythm, complete heart block, another dangerous rhythm, VT can be regular. Now regularly irregular, you see the fixed AV block. Either 3 to 2, 4 to 3 conduction. What is the 3 to 2 conduction? You have 3 P waves, atrial waves, only 2 are conducted. 1 is missing. So, 2 out of the 3 impulses, 2 will produce a pulse. So, you have 3 to 2 conduction means out of 3, 2 will produce pulse. So, after 2 pulse, there is a gap. 2 pulse, there is a gap. This is called regularly irregular. If you have a 4 to 3 conduction, out of 4 pulses, out of 4 electrical activity, only 3 will produce a pulse. Means after 3 beats, a gap. After 3 beats, a gap. So this is called regularly irregular rhythm. Again, this can be for AV block or SA block. This should be the ratio 4 to 3, 5 to 4 like that. Any ratio of this kind will produce hypervolemic pulse, hyperkinetic pulse. Yes. Now most of you may be having. If I ask you something, suddenly your sympathetic system goes up, you may have a bounding pulse. Fever, anxiety, hypothyroidism, pregnancy, anemia, and the rare condition called delivery thiamine deficiency. Okay. So that is hyperkinetic, first one. But one I have mentioned specifically, what is that water hammer pulse? It's again a hyperkinetic pulse. Hyperkinetic means the amplitude is very high, the rate of ascent is very steep, and there's a certain decrease. It's called hyperkinetic Bispherians pulse. So aortic regurgitation, severe, you have a Bispherians pulse with a high amplitude. So it's a hyperkinetic pulse. Let us see what is water hammer pulse in severe aortic regurgitation. This is the waveform. You see a rapid upstroke. By peak, 2 peaks, the percussion tied up, the rapid downstroke, which resembles the feeling produced by a Victorian era toy, Victorian, England, a water hammer, which contains fluid vacuum. So it just flip like this, sudden kind of, this fluid movement produces a collapsing field. This collapsing field can be reproduced in severe aortic regurgitation by doing this. Ask the patient to lie down, feel the pulse, get the heel of the palm, get the pulse, suddenly raise, then collapse you will get. I'll show you. This is the Corrigan's pulse, actually dancing carotids. It is the carotid artery equivalent of the collapse. You feel collapsing in the radial artery, and this is the equivalent in the carotid. You have it like that, okay? Okay. Now the opposite one. We'll go to the previous slide and show you. The second one, hypokinetic pulse. Hypokinetic pulses parvus etc. Hypokinetic is low volume pulse. You are dehydrated, you have a lot of diarrhea, blood loss, accidents, and then of course severe aortic stenosis, outflow obstruction. You have a low volume pulse. And the classically severe aortic stenosis pulses parvus etc. What is TARDUS? You see the normal pulse. The upstroke is rather steep. You see the parvus. This is the TARDUS part. TARDUS means slow. Slow upstroke. See the amplitude of the pulse. This amplitude is high. The amplitude is low. This is parvus. Parvus is small. So pulse of parvus at TARDUS is self-explanatory. You have a TARDUS part. You have a low amplitude parvus part. It's a very important pulse sign in severe aortic stenosis. Most of the patients here you can palpate, you will get this form of a pulse because we see a lot of severe aortic stenosis patients here. Bifid pulse. That's the third character of pulse. 2 peaks. Bifid means 2 peaks. There are 3 groups. Bispherians pulse in aortic regurgitation, ASIR combination, sometimes fever and exercise, okay. You have 2 systolic peaks. See the dicrotic notch where the aortic valve closes. This is due to aortic valve closure, I told you. So this part is systole, this part is diastole. So see the peaks are in the systole. Peaks are in the systole. Again, these 2 peaks are in the systole. Here what happens in dicrotic pulse? 1 peak is in the systole and the second is actually the dicrotic wave, which is very prominent. It takes so much time to come back. The reflection takes so much time to come back in a bad patient. For example, cardiomyopathy, severe LV dysfunction, hypervolemic shock. So you will feel 2 systolic, one systolic and 1 diastolic peak. So when you feel the brachial, you will get 2 peaks. If the peaks are too much separated in a patient with hypotension, always think of this thing, severe LV dysfunction, dicrotic pulse. Here again, it is percussion wave, tidal wave. Here again, percussion wave. Now let us see the conditions. Bispherians pulse, I told you. This is the spike and down pulse in hypertrophic obstructive cardiomyopathy. It's a condition where there is an obstruction below the aortic valve. So initially there is a rapid flow producing a large percussion wave. Suddenly there is an obstruction causing a dip and then a dome. This is called spike and dome. The spike and dome is again a bifid pulse seen in hypertrophic obstructive cardiomyopathy. Fine. So these are the 3 bifid pulses alternates. You see the graph. 1 beat produces almost 120 millimeters of mercury pressure. The second beat is around, maybe some 100. So this may not be felt as a pulse. This may not be felt as a pulse even. Or you may feel strong, weak pulses. So this is mainly due to LV failure. If you see the pulses alternates, you are almost sure that the left ventricle is severely bad. because the left ventricle, because of the calcium, basically it's the calcium mechanism. Get a lot of calcium, first contraction will be good. Everything get depleted, second contraction bad. Next contraction, little more calcium, good, bad, like that. So it is something related to the calcium recycling in the left ventricle, in a bad left ventricle. Paradoxes. What is paradoxes? Pulsus paradoxes is an exaggeration of the normal phenomenon. During inspiration, because of the negative intrathoracic pressure, all the pulmonary veins will keep the blood inside. The LV filling will decrease and the LV outflow will decrease. The pulse volume come down because of the decrease in the systolic BP to up to 10 millimeters of mercury. Up to 10 millimeters of mercury. If it happens more than 10 millimeters, you will feel a weak pulse during inspiration, more than 20 millimeters. And using a sphygmomanometer measurement, you can actually assess it. I don't have time to tell you how to do that, but you come and learn because it's an important sign in pericardial diseases. Pericardial tamponade. Okay, so very important. So paradoxes is nothing but an going fast. So paradoxes is an exaggeration. Paradoxes is an exaggeration of the normal phenomenon. So an inspiratory decrease in the LV filling to produce an inspiratory decrease in the systolic BP to more than 10 millimeters of mercury during inspiration. Can you tell me why there is an inspiratory decrease in the systolic BP up to 10 millimeters? I told you now. Yes, together. Negative intrathoracic pressure does what? All lung and the pulmonary vein, they hold the blood back. They won't allow to go to left ventricle. That is why a little bit of reduction. But if you have any problem with the left ventricular filling like pericardial tamponade, the already impaired inspiratory kind of filling will further impair. Because already filling is impaired because the pressure from the pericardium to the left ventricle. The tamponade has a unimodal kind of filling instead of the bimodal filling. So what is the paradox there? It's an exaggeration. You should have called pulsus exaggerators. It's not called pulsus exaggerators. What is the paradox? So paradox is here. It's a paradoxic pulse. Peripheral pulse disappears during inspiration, yet apical impulse is felt. You will feel the impulse there, suggesting that heart is contracting. During inspiration, heart is contracting, but you feel an absence or diminished pulse. That is the paradox. With persisting impulses during inspiration, your pulse is coming down. That is the paradox in pulsus paradoxes. So you need a sphygmomanometer to demonstrate paradoxes. If you have more than 20 millimeters of fall in the BP, I have seen several times, I have actually diagnosed tamponade with only just palpating the pulse. Ask to take deep inspiration, even some of you can even feel, if your fingers are that sensitive, during inspiration, the rate goes up and there is certain decrease in the volume. It may be very difficult, but it may be possible. Okay, the conditions are cardiac tamponade, emphysema sometimes, yes, post-thoracotomy like all this mitral valve repair and all, constrictive pericarditis with effusion, and pulmonary embolism. See, this should be the first thing. A patient coming to the casualty with hypotension, tachycardia, you don't know what is happening. When you take BP, look for paradoxes also. And if you demonstrate paradoxes, you are almost dealing with a pericardial effusion causing tamponade. Okay. So this is how paradoxes looks like. This is the pneumogram. You see the inspiration. When the inspiration, you see the amplitude of the pulse. It comes down. It comes down. The amplitude comes down. You feel a decrease in the pulse volume. During the expiration, you see the pulse amplitude. It's very high. Stop. Reverse. This is a PG level thing. if you have intermittent positive pressure ventilation, you give positive pressure from the ventilator. So instead of negative intrathoracic pressure during inspiration, what will happen? There is a positive intrathoracic pressure. That will cause inspiratory increase in the pulse volume. You understood the mechanism? Our body produces negative intrathoracic, but when you give ventilator pushes the air in with pressure. Okay. And second is isorhythmic AV dissociation. Means P wave is beating separate, B wave is going separate, but they are almost similar rate that they go together. During inspiration, P goes a little ahead. Suddenly the AV volume increases. Because AV synchrony happens. You understood? So this is the second condition. It's a PG level thing, but you can study. Now radiofemoral delay. From the heart to the carotid, 30 milliseconds. To the brachial, 65 milliseconds. To the radial, 80 milliseconds. To the femoral, 75. See, these two are 5 milliseconds difference. You won't feel the difference. Your fingers can't take up that difference. So, if you have severe aortic stenosis, if you have coarctation of aorta, what will happen? This will become more. It will become 100. There's a TARDIS part. The peak become delayed. It's not the pulse that become delayed. The peak become delayed. So you will feel separate. You have to feel the radial and the femoral simultaneous. Side by side. And usually you get both together. If you feel the femoral pulse later than the radial pulse, that's called radial pulse. And that is diagnostic of aortic obstruction. Maybe due to aortic stenosis, coarctation, maybe due to atherosclerotic aortic disease. So now the peripheral pulses. After you see, rate, rhythm, volume, character, radiofemoral delay, everything, then you come to the peripheral pulses. You see all the pulses. I told you the pulses. And if you have an unequal pulse, you have all these conditions. I start with the heart. You just start from proximal to distal. See, supravalvular aortic stenosis, where you have an obstruction there, aorta above the valve. The aortic dissection, the most important. A patient coming with chest pain, severe pain. You have unequal pulses, either the carotids or in the radial or brachial. What is the diagnosis? The dissection obstructs some part of the origin of some arteries. Dissection will go spiral. It will spare origin of some arteries. So some arteries will be felt. So if you have pain with unequal pulses, peripheral pulses, that is, what is the diagnosis? So I have given them in red. The case of arthritis, I have given black. Cervical red black, because these are not immediately life-threatening problem. But if you have an unequal pulse in the casualty, think of this aortic dissection, arterial embolism. A patient with pain, severe pain, upper limb, lower limb, no pulse. Diagnosis confirmed. You don't need Doppler. You don't need a CT angiogram. Arterial embolism or thrombosis. The last one, vessel wall thickening. You use 3 fingers, the index and the ring to occlude the blood flow, and this middle part you just roll to see. Try to roll and you see this very thin. Your vessel wall is very thin, very fragile thing. But conditions like Monkey-Bell sclerosis, the radial artery, you can see the artery is thick, and you see the radial artery here. It's very thick, calcified. You can feel the calcium, especially in diabetes patient, chronic kidney disease patient. You can see this phenomenon. The vessel wall is so much thickened. Okay, now that we finished the pulse, I think you understood something. Did you understand something?
Yes, sir.
I'm ahead of time. Okay. Now, this diagram I want you to learn and memorize until you exit clinical medicine. This box diagram is pretty good. It explains everything, the hemodynamics of heart. I will start from here. Right atrium, tricuspid valve, right ventricle, pulmonary valve, 2 pulmonary arteries. For here only one is shown. 2 pulmonary artery to both lungs. There are 4 pulmonary veins coming to the left atrium, mitral valve, left ventricle, aortic valve, aorta, going to the whole body, going to superior vena cava, inferior vena cava, again right. Okay. Understood. Very simple. Which part of this system we discuss right now? This part. You assessed how to assess this part. You learned the pulse. You learned it. Now which part we are going to learn? This part. We assess the arterial system. Now we are going to assess the venous system because venous system has got a pressure. It has got a pressure. But it is very, very, very minuscule compared to arterial pressure, which is 120/80. Your venous pressure is 6 millimeters of mercury. You can't measure it. So how do you measure? You measure the peripheral vein pressure. Do you have a sphygmomanometer that's sensitive? No. You measure because God has given you an internal jugular vein, which is in direct connection with the superior vena cava, which is in direct connection with the right atrium and right ventricle. So, jugular venous pulses and pressure will give you an idea of right atrial pressure during all cardiac cycle and right ventricular pressure during diastole. Because during diastole, RV and RA are open together. They are a single chamber. Tricuspid valve is open. You understood? Now that's the concept. This is how to measure 45 degrees. This is the sternal angle. You have to come here. At the suprasternal to just go below. You palpate. You palpate. Everyone, come down, come down, come down. You see that the kind of that sternal angle and something called a phlebistostatic axis of Birch, which I have not mentioned here. It's a static point of right atrium, which is always 5 centimeter below the sternal angle. So this is the right atrium, 5 centimeter below the sternal angle. So up to 5 centimeter jugular venous pressure is normal, because normal JVP is 6 to 8 centimeters of water. But if it goes above the sternal angle, the suprasternal notch, it will be visible here. So this is, suppose this guy has an elevated jugular venous pressure, and suppose this is around 4 centimeters. You see, you place a scale vertical from the sternal angle, another scale horizontal from the top of the pulsating column. You measure this part 4 plus 5. 4 plus 5, 9 centimeters. So that is the jugular venous pressure in this patient. Elevated or normal? 6 to 8 is normal. So it's slightly elevated. Slightly elevated. Okay. Now have you understood how to measure? 45 degrees may be cumbersome. It may be cumbersome. I usually do what I do is it's a tip, not for examination. Practical tip. When a patient comes, you make him sit up. If it is visible above the clavicle, it is elevated. It's very simple. 45 degree and taking two scale, 5 minutes, patient may go upwards. It's a very simple thing. Make him sit up, he will be just, with a sort of lot of dyspnea, you won't be able to lie down. Make him sit up, just look at the pulses, root of the neck. You see, JVP is elevated, you know that the right atrial pressure is elevated and right ventricular diastolic pressure is elevated. This is, again, memorized. This is the most complicated part of jugular venous pulse. Naming the waves and naming the mechanisms, how to decipher the mechanisms of jugular venous pulse. There are 3 plus and 2 minus. Arterial wave, pattern, percussion, anacrotic, tidal, and dicrotic. Likewise, here we have 3 plus and 2 minus. Remember like that, 3 plus and 2 minus. Out of 3 plus, this C, small plus is, you can't see. You can't see. You can see only 2 plus. A and V. And you can see 2 minus. X and Y. Let us see what all things happen inside the heart during these waves. Let us come to A. A stands for atrial systole. Just write down. A stands for atrial systole. Atrial systole is the atrial contraction. Last 0.1 seconds. Okay. So this is the diagram showing that atrial systole. Atrium contract, and if all the blood is ejected. Now, after the AV, there is a sudden decrease. What is happening? After atrial systole, what will happen? You study. At night, what will you do? You sleep. Relax. Atrial systole, A wave. Then X descent is relaxation. Is equal. Atrial relaxation. Relaxation, there is an X. So you can take the X out of it. You understand? X wave is due to atrial relaxation. X in the code, you have to add one more thing because all these waves relate to the atrial events. But ventricle is also doing something there, na? Ventricle is no. Is it sitting while it is doing something? What will happen during atrial relaxation? Ventricle is contracting and tricuspid valve is closed. So during X wave, two events. What is the first event and most important event? Relaxation. But ventricle is working, contracting with a closed tricuspid valve. That's the second picture. Valve is closed, ventricle is contracting, ejecting blood into the aorta, atrium is relaxing. And third one, the positive V wave. No, I forgot to mention the C wave. The tricuspid valve closes now. When the LV contract, the RV contract, the valve pushes little into the right atrium. Valve bulges into the right atrium a little bit of LV contraction. That produces a slight increase in the pressure. That's the C wave. Some people say it is because of the carotid artifacts. Carotid pulsation will produce some wave. But both mechanisms we can say. And I will say because the tricuspid bulging into the atrium during the atrial relaxation produces a small thing which is not visible. C wave is a measurement thing with a manometer. Okay. Now you come to the V, X relaxation. After relaxation, atrium is relaxing, but blood is coming inside. Through Vinayakava. Blood is coming inside. So the pressure rises up. Now the blood is filled. Remember here relaxation. Blood is full. Atrium is ready to empty the content into right ventricle. So this part, again pressure builds up due to V. So V is, what V stands for? Tell me what V stands for.
Venous filling.
Huh?
Venous filling. Venous filling.
Very good. Amazing. Actually it stands for ventricular systole. V stands for ventricular systole. But you can alter it. Venous filling. Okay. Atrial systole, atrial relaxation, venous filling. But again two events happen there. Again ventricle is in systole. Tricuspid valve is closed. And the last event is what? The Y descent. Tricuspid valve open, the whole thing goes into that. So Y descent stands for what? Emptying. Atrial emptying. Empty, there is a Y. Empty. That Y. You understand? So it's very simple. I think I have made it so simple. It's very difficult to remember. So just remember this way. Atrial systole A. Atrial relaxation X. C wave due to tricuspid valve closure. C you forget because you don't see it. Then V wave. Venous filling. Ventricular systole. V stands for ventricular systole, not venous filling. Then Y is atrial emptying. Remember this. Then you will know all the conditions related to JVP problems. If you remember this properly, the puzzle is solved. You are done with it. Fine. How do you differentiate? It's a very enigmatic, very tricky thing. Many people don't know how to differentiate. So the first thing is, the venous waves have got multiple waves. Two A waves and two positive waves and two negative waves. So it's undulant. What is undulant? What is the meaning of undulant? Undulant is like a wave flow. You see the waves of a lake? Waves in a pond when you put in stone. That ripple is traveling smoothly. That flowing thing is the undulant. This is exactly what happens in JVP. It will be like smooth wave-like thing. But arterial pulse is like an outward movement, a single movement. Better seen, better felt. The descents are not prominent. Descent is not prominent. The positive is prominent. In JVP, the descents you can see. The X descent you see. rather than the positive waves. Artery can't, because artery's pressure is 120 or 80. You can't completely obliterate. You understood? Fine. Then of course it can vary with posture, inspiration. Inspiration, it comes down. Posture, sit up, goes down, lie down, it comes back. And of course, pressure, abdominal pressure, transiently it elevates. So if you give some pressure, gentle pressure, the epigastrium or the right hypochondrium, slight elevation, transient, it is jugular venous pulse, not arterial pulse. And a little lateral, little medial. Okay. How to time? Another tricky thing, nobody knows, students and me. You palpate the carotid pulse. You see the pulse almost time with it time with the X descent. But if you compare the A wave and B wave, it is more in line with the V wave. So if you can palpate the carotid pulse, he's my teacher again. So if you can palpate the carotid pulse on the other side and you see a wave which happens in synchrony with the carotid pulse, that is the V wave. Out of sync with the carotid pulse is the A wave. Very simple. You remember this diagram because systole, this part X is the systole. I told you relaxation ventricular systole produces pulse. So during that pulse you have that V wave. So X and V is atrial relaxation ventricular systole. So the pulse will coincide with what? V on A? V wave. This is the worst part of it. I don't like this definition. So that's why I put definition little later. I wanted you to understand the concept rather than defining and mugging up and then just regurgitating in examination hall. You understand? So I will read it for you. It is defined as the oscillating top of the column of blood in the proximal portion of IJV and represents the volumetric changes, not the pressure change. The volumetric change that faithfully reflects the right atrial pressure during all the phases of cardiac cycle. I have given 4 in red letters. It's the oscillating top. It should oscillate in the IJV. It's a volumetric change that you see, but you can decipher the pressure changes. So it is influenced by a lot of things. We will start from the vein. See, if you have a lot of blood here, JVP will be elevated. For example, chronic kidney disease, no urine, blood volume is high, cardiac failure, congested, you have elevated. And see the venous tone, you are anxious, all the veins are contracted. You understand? Then what? Right atrial contraction. See, now we come to the SVC and the right atrial. If the right atrial is not bad, good. There is some problem with the right atrial filling or contraction. Again, elevated. Closure of the valve, tricuspid. If you have a problem with the tricuspid regurgitation, stenosis, you have the JVP. And then the ventricle. Right ventricular diastole and intrathoracic pressure. Anything that happens in the thorax, in the pericardium or in the abdomen. 3 pressures. If you have an intrathoracic pressure elevated due to pleural effusion, pericardial effusion or even ascites, will affect the jugular vein. So you should know these things can influence the jugular venous. So normally 6 to 8, the conditions are elevated jugular venous pressure, cardiac failure, blood volume, increase intrathoracic pressure, intrapericardial pressure, intraabdominal pressure, tricuspid stenosis, partial obstruction of superior vena cava, hyperkinetic circulatory state where venous tone is high, you have a lot of constriction, you get false elevation, then space occupying lesion affect the right side of the heart, for a tumor, right ventricular cardiomyopathy, consecutive pericarditis, a slow heart rate is not that at all. Right? See, if you know the concept, you can kind of list all the causes. Now, see, this is the jugular venous pulse. See the undulant nature, see the undulates. A flow, a wave. You see that? You see that? See, multiple waves are coming. You can see actually two waves. You can see two waves there, two positive. Can you see? Can you? Yeah. Now you compare with that previous guy's Corrigan's pulse. Single bulge. If you have a normal JVP, it's not elevated, patient is still listening, no edema, you are thinking, hey, I am missing something. He is having cardiac failure, or he is having elevated pulmonary capillary wedge pressure, right, left atrial high pressure. How will you elicit? You don't have hepatojugular aplasia. Some mild pressure, patient will be in severe distress. Now in the casualty, it will just like anything. You keep him 45, just apply some little pressure, don't cause too much of pain in the epigastrium or the hypochondrium, and apply for 10 seconds. Up to 10 seconds, there may be an elevation more than 3 centimeters. But usually, the right ventricle can accept it. So after 10 seconds, the mesh will come. If you have a failing right ventricle, it can't accept. So the elevation will persist more than 15 seconds. So the positive hepatojugular reflex is a sustained rise more than 3 centimeters for 15 seconds. You learn this by heart because this is the examination point. You get it positive in right heart failure, left heart failure, and very good correlation with the BNP, right atrial pressure, and pulmonary capillary wedge pressure is some indirect pressure of the left atrial pressure. So it reflects left atrial, right atrial pressure. So it can be a surrogate marker. Well, we saw elevated JVP causes, we know the concept, we know how the waves are formed. Now we see individual waves, not very much. Sir, I never showed you, sir. So we will start with the A. We will start with the A. A is due to what? Loud. It will
Systole.
6 more minutes. Atrial systole. Atrial systole. So anything in the right side which increases the pressure during atrial systole will produce an elevated airway. Just read out everything, right? Loud. 1, 2, 3, 4. Loud.
Severe pulmonary hypertension.
Why severe pulmonary hypertension? Pulmonary arterial hypertension. How will you produce elevated? Because they are in series. Below the pulmonary artery, you have the capillaries and the veins. So if you have severe pulmonary hypertension, you have the venous hypertension coming because they are in series. RV diastolic pressure goes up. So atrial pressure, A wave goes up because RA has to contract strongly. RA contraction is the A wave. So any time when the feeling is difficult, RV is telling, no, I won't accept the blood you give. RA will try to push over. Then read the second. Same thing. Again, RA has to push. Yes? Same thing. There is an outlet obstruction. RA will do what? Try to overcome the resistance. Yes? Burnham syndrome is nothing but intraventricular septum bulge into the right side due to a left ventricular problem. So the ventricular septum is part of both RV and LV, is in the midway, imagine like that. And if you have some problem like aortic stenosis or cardiac failure on the left side, the septum will bulge toward the RV, impairing the RV filling. So RA will do what? The same thing, try hard. Then what? Tricuspid atresia is a severe form of tricuspid stenosis. It's a congenital condition. Will be seen in 1 year, maybe 6 months. Cannon wave. Giant wave is different from cannon. Cannon is what you know cannon. Cannon, you know cannon, water cannon, sudden outburst. The mechanism is the right atrium is contracting against a closed tricuspid valve. Usually what happens, the P wave precedes the QRS in ECG. The right atrial contraction happens, then only the left ventricular contraction. If they happen simultaneously, what will happen? RA will be contracting, but nothing will be going to the RV. Everything going back to the jugular vein. That will produce a sudden burst. That is called a cannon. So it's a giant wave, but little more giant. Gianter or giantest. No, you understand? You have regular cannon, junctional rhythm, PSVT. Understand all these conditions, P and QRS occur together. P and QRS occur together. So what will happen? The tricuspid valve will be closed because ventricle is contracting, atrium is contracting simultaneous. So regular means junctional rhythm regular, P and A are together. The impulse originates from the junction, AV node. Goes back to atrium, comes down to ventricle, together they are contracted. SV. Irregular means complete heart block and multiple ectopic ventricular tachycardia. Here why it is irregular? Only at times P and QRS will come together. Other times we will precede the QRS. So at times nothing will be there. Suddenly there comes a. So if you see regular junction, that's good actually. Why? Junctional rhythm and PSVT are not life-threatening. They are not life-threatening. In a casualty, patient comes with tachycardia, very heart rate. You feel 150 per minute, BP is 100. Then you look at something suddenly bulging out. Regular. Oh, sandosham, PSVT, adenosine kodutha. Junctional rhythm, digoxin matiyam. But here, if you have a regular alland canon, you will think something is not there, good there. Something is really bad happening. If it's a tachycardia, ventricular tachycardia. So bradycardia, complete heart block. So this is a canon wave. You see that? See that? Sort of like a cracker going on. No? You see that? You see that? You can come there. We see often heart blocks there. You will see that canon waves, provided you are interested. Now we saw J&J wave, canon wave. So there is a counterpart, absent wave. When the atrium is not contracting, atrium is very weak, like in atrial fibrillation. Atrial fibrillation is compared to a bag of worms. Undulation only. There is hardly any contraction. So there is no A wave. So in their JVP you will see only a V wave. Only a V wave, single wave. Okay. And Epstein's anomaly is a congenital condition where you have an abnormal tricuspid valve. Atrium is hugely dilated and not at all contracting, no contraction. So that's why Epstein's anomaly may produce absent AV. Prominent X descent. Now we come to the descent. X is due to what? Atrial relaxation following atrial systole with a closed tricuspid valve. So ASD. Why ASD? Atrial septal defect is a defect between the atrial septum. So all the left atrial blood is going to right atrium. So lot of blood in the right atrium, suddenly emptying down. So you have a large A wave, an X descent. Because there is a large A wave, there is an X descent. You understand? Only because the excess blood suddenly emptying. And the second and third condition, constrictive pericarditis and pericardial tamponade. What will happen is, I will tell you how this happens. So there are two phases of healing. There are two phases of healing. What are the phases? One is X wave, relaxation, and second is the V wave. You understand? During X wave, valve is closed, LV is contracting. During V wave, Y descent, valve is open, LV is relaxing. Here it is a single unit. That's the difference. Suppose LV has a problem with filling. What will happen to the Y descent? For example, a tamponade situation, LV is compressed, constrictive pericarditis, thickened pericardium, compressing the LV, what will happen? The Y part will come down because that is the time when LV is open to the right atrial, left atrial flow. You understand? If Y descent comes down, naturally the whole blood has to go down during the X descent. You understand? That is why you get deep X descent in pericardial tamponade and a unimodal filling state where Y is gone because the pericardial pressure, LV is collapsed. LV can't take in. So the whole blood will go down during the X descent. So if you have a deep X descent, the first answer for the deep X is pericardial tamponade. Why? 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 Y is gone. Only X. The whole blood has to go down. 60 to 70 ml per beat. It has to come down. Now, 130 ml of blood has to come down, not 60 to 70. It has to go down through the X-descent only. You got my point? So the concept is important. No, don't look at it. It's very simple. You understand? Fine. Prominent V wave. After the exhale, you have a V wave. V wave is due to ventricular systole. Tricuspid valve is still closed. There is filling happening, and that is causing the pressure. So the problem is Lanxess sign, severe TR. What will happen here? See the V wave here. The tricuspid valve, there is a regurgitation back to the right atrium. The V will go up. You understand? In tricuspid regurgitation, the blood is going back to the right atrium. So what will happen to the V pressure? The blood is going back, V will go up. You understand? You understand?
Yes, sir.
Say loud as if you are confident.
Yes, sir.
Yes. Today you go and read, you will understand further. So V wave, prominent for practical purpose for you is severe tricuspid regurgitation during the third phase, because that's the phase when the valve should be closed. If you have a regurgitation, the blood comes raising the pressure, raising the V wave. ASD is nothing, simple. All the lateral blood is coming to right atrium, so all the waves should be prominent. So if an examiner asks you prominent A, prominent B, prominent X, prominent U, you can say ASD and explain, sir, all the blood is coming to right atrium. You understand? So 1 mark you can get. Again, in constrictive pericarditis, it is prominent V wave because of the loss of compliance. Loss of compliance in the TR should be there. Lanxess sign is a very very amazing name. This is the prominent. You see the V wave there. See how bad. See the V wave there. It is going all the way into the brain. See the V wave. So this V wave is due to what? Tell me. Loud. Severe TR. You diagnosed. You became a cardiologist. Diagnosis finished. You don't need echo. You come, cardiologist come 5 minutes later. You say, sir, this is severe TR because I saw the Lanxess sign. Cardiologist is finished. Okay. Deep wide descent. Again, another sign is called Friedrich's sign. Just remember that. In constrictive pericarditis, pericardium is thick, so the filling is impaired. I told you, na. So the X is prominent. I told you already X is prominent. But in Y, there is a difference between pericardial tamponade and constriction. Pericardial constriction, the early 1/3 of that Y part will be prominent because that time, up to that time, ventricle can fill. Then suddenly it faces a thick pericardium. Suddenly the filling stops. So the initial part, 1/3 of the part Y will be prominent. That is called Friedrich's. But not in constrictive pericarditis, where LV is completely, RV and LV are completely compressed by the pericardial tamponade effusion. In constriction, it's not compressed, it is restricting. So initial part of the Y will be there. Suddenly there is a halt due to the thick pericardium. So that's why you have prominent X and Y, prominent X tamponade and constriction, but prominent Y only in constriction because initial part of the Y will be there. You understand? Because thick pericardium won't impair totally the filling. It will only halt the filling during the later part of the Y. Okay? So in pericardial tamponade there is no prominent Y descent because there is a pressure from the outside. It will not allow any filling during Y. That's why only X is prominent. You understand? So in pericardial tamponade, 2 signs. One pulse sign. Tell me what the pulse. Tachycardia will be there. Sinus tachycardia. Patient will have 110, 120. BP will be low. What sign? Tell me. You take the sphygmomanometer. Do one thing. What is that? Pulsus paradox. And look for one JVP sign. What's that? Prominent X descent. Don't forget. Small sign. During normal inspiration, because of the negative intrathoracic pressure, all the blood will be sucked in. You don't see any change in the JVP, it may even go down. But if you have a problem with the RV filling or RI filling, whatever coming inside will not be going into the heart. They can't accept. So what will happen? Suddenly there is a paradoxical increase in the jugular venous pressure. So the paradoxical increase in the jugular venous pressure during inspiration is called small sign. Again, anything that impairs the filling, constrictive pericarditis, right heart failure, restrictive cardiomyopathy. anything that impairs filling in the right side. You inspire, all the blood rushes into the heart, but heart will say, no, I can't accept. The JVP goes up. You understand? Fine. Thank you very much.